I am the medical physicist for the Huntsville Hospital health system in North Alabama, United States. I would like to share our approach to dose management. Dr. Bidman made a very good introduction and described quite well all the benefits of CT imaging. It's the workhorse of diagnostic imaging nowadays, and it is invaluable in for diagnosis of multiple diseases. We can slice and dice the data in many ways. We could use visualization tools and just show the heart and the blood vessels, or we can just eliminate the lungs or eliminate the bones. Any way we want to look at images, especially the newer scanners offer deep learning artificial intelligence algorithms for image processing and data analysis. It is here to stay, but it is our responsibility to try to optimize the image quality and the dose in such a way that we're not missing information, but we're not harming patients as well. This is not an easy task, and it is an ongoing process. You have to stay current with the newer developments, and you have to be very diligent about knowing what the machine can do. It is pretty much a spaceship. It has all these controls and things that can affect the image quality. They can affect the dose. It is no longer our simple X-ray diagnostic room where you can learn to operate fairly quickly. And with the new technologies, we're getting more and more sophisticated software options, a whole lot of choices we can make before we scan that patient. So making sure that our staff can pick their choices wisely, it's a more difficult task than I realized at first when I started doing this. So just to give you a little bit of a overview of the scope, what we're working with here, Huntsville Hospital is the second largest hospital in Alabama. We have about, I think the latest number is 11 hospitals across the state, maybe about 20 clinical facilities that do imaging. One of our hospitals is actually in another state, in Tennessee, and we keep growing. And currently we have about 25 CT scanners. We're about to add another one. And last but not least, we have 5 radiology groups that we need to work with. In addition, the population of Huntsville, Alabama is ever increasing, and we have to meet the demand, which means more CT scanners are coming and more medical facilities most likely. So just at the main hospital, we do approximately 120,000 CT exams a year. And trying to standardize scanning patients is difficult for also for the reasons that everybody has different training, different practices and policies, especially when we add more hospitals to our health system. We have to look into their protocols, their equipment, things I will explain more in the next few slides. So we have equipment from 4 different vendors. Even if the equipment is by the same vendor, mostly we have GE scanners, but we have anywhere from machines that are end of life to machines that have deep learning algorithms. And we're about to add the a photon counting alpha scanner from Siemens, which adds to the complexity. What we need to make sure is that our technologies are not cross-trained among different scanner vendors in the models. They need to be trained to understand what the machine is capable of doing and what we're allowing for them to do on that machine. As you can see, we got 16 slice, 256 slice machines. Sometimes, even if it's the same model, the same vendor, the hardware is not quite the same and cannot perform the exact same scan with the same technical parameters. So we need to watch out for all these things. When I started working at Huntsville Hospital, this was 12 years ago, and this is where we were. At the beginning, to this day, Alabama does not require licensure for radiology technologists yet. Each facility provided little training, each of their own requirements. It also depended on who was the application specialist that came on site. It depended. Sometimes technologists would train each other. There was very little training on dose, what the dose metric were, and also they did not understand how changing slice thickness or tube voltage, how that affects not just the image quality, but the patient dose and the consequences of those things. So in addition, we have radiology groups. They have their own preferences on what the CT protocol should look like. And that does not just involve different reconstructions, but also technical parameters. We had many instances to where a physician would walk into the CT room and demand that some patient is scanned certain way with no consideration of, the patient dose. This, I need to emphasize, this was over 10 years ago, right? We've moved along and we've made tremendous progress since. I have also encountered clinics that did not take advantage of the application training after new installations or software upgrades. So other things that were lacking, our protocols were not locked on the scanners. We could have vendors come on surprise visits and state that I came here to modify such and such protocol, and normally they would be allowed to go and just do their thing and nobody watches what the consequences of that is. We had protocols with the physician names on them. We also had protocols that were specific to technologists. One facility I went to do the annual physics testing. I asked the technologist, I said, well, I see several pediatric head exams. Which one do you use regularly? She says, oh, no, that depends who scans it. I said, what do you mean? They said, well, I'll use fake names. Mary likes this one, I like this one. I said, well, what do the radiologists say? They don't say anything. So that had to change, of course. There is very little to no supervision on second or third shift or on weekends. To this day, there's some difficulties, monitoring these folks, but we're getting there. So yes, you saw the infamous, we call it the Huntsville haircut. As a result, our hospital was involved in one of those class actions lawsuits, and we're not proud of it, but the hospital realized that probably they need a physicist on staff, and I was hired, after these things happened. And I was tasked to make sure that this does not happen again. So I will share with you what it is that we have done. So the first thing we did was to gather a task group. And back then we met every month and we would discuss what kind of training and competency is adequate for our facilities, what kind of quality control we'll be doing, not only on monitoring the protocols, but on the CT performance. We created a policy and procedures manual that outlines all these things. It outlines competencies on the specific scanner features, outlines competency on how to use the injector, safety. We have several of them. Then we would do CT protocol discussions. If we use a dose monitoring program, so every once in a while we pull a CT exam that was not performed properly, and we use it as a teaching education tool. So we, when we have the meeting, we sit down and we say, this is how this patient was scanned. This resulted in such and such dose. How about, and radiometrics, the radiometric software also gives us the organ doses and how they change when you change the different parameters. So we've done that in the past where we say, okay, if you scanned it the way we required, the dose to the eyes would have been 40% less. So that hits home. I think the visuals that we use, the education, I think it's paid off. We have also started different benchmarking activities. We participate in the dose index registry from the American College of Radiology. So we can compare our doses with the rest of the country. We also use the radiometric software, and with that software, we do internal benchmarking. Different facilities, different scanners, we watch how we watch performance that way. We also participated in several projects with Dr. Bindman. One of them is Partnership for Dose with University of California at San Francisco. We were very grateful for that experience. In fact, we had the opportunity to exchange ideas, experiences, workflows with folks from 150, I believe, different hospitals from around the world. We also participated in the development of the electronic clinical quality measure with ALARA imaging. And we had very good, insightful feedback from that experience. And we're grateful for that also. It's been very, very good for us. So what kind of dose reduction activities we've done? The first thing you got to do is to lock these protocols on the CT scanners, on all of them. If a representative from some company comes and wants to change the protocols, they have to go through a process. And this process includes the radiologist, the medical physicist, and the lead CT technologist. We all need to agree that whatever changes need to be made make sense, and they will not unnecessarily increase patient dose. We do realize that Sometimes we do need to increase the dose, and that's okay, as long as it makes sense. We don't want to have useless low dose protocols, but we don't want to have unnecessarily high dose protocols either. So any changes are done with a discussion. We have developed, it took us about a year, but we have developed reference CTDI and DLP values, above which technologists have to explain why they needed to exceed it. This is not to reprimand them. This is just to kind of track, maybe we need to change the reference. For a long time, we haven't needed to change it, but at the beginning, it was a good feedback. We also need to identify if these technologies are needing more training, or if they're needing more training. So, for example, if all our experienced good technologies are able to fit within those reference values, then maybe someone that's consistently above them need to be retrained. That's what I mean. We have a dedicated quality technologist who monitors outliers, investigates why they happen. And this is being done on a weekly basis. So if people need more guidance, then we provide it. So what are our current training requirements? We give them about 13 months to register with ARRT. They go through 6 months of CT training that includes scanner operation competency, injector competency, and CT exam competency. So we are very serious about letting them go solo when we feel like they're ready. We have weekly reviews with the new technologies. And those reviews include how many scans they've done per week, how many alerts they have gotten, and so we use GE scanners, and how many times they overrode the dose check feature on those scanners. They will not scan unsupervised while in training. Well, lately we've had a lot of turnover, so this has been very challenging. But we try to stick to the maximum to our requirements. So, what kind of policies we develop? We develop policy that requires that there is limited access to protocol changes, and it outlines what kind of communication is required if the dose is likely to be affected. We have a policy on stating that there has to be a mutual agreement between the lead CT tech, the physicist, and the radiologist. So on an annual basis, we do protocol review. We also review it on quarterly, one protocol on quarterly, one or two maybe on quarterly basis during our CT task group meetings. And we also have a policy on dose monitoring, which outlines how often we analyze outliers, what are the corrective actions or any actions that need to be taken, and at what point these actions need to be taken. So this way everybody is treated fairly. And they understand that this is a policy and it's not something that we just made up on the fly. So we would like to touch up on our dose monitoring, how we do it. So our lead CT coordinator, he does daily review of the alerts. Because we do so many scans, it is unrealistic to try to do them on a monthly or even a weekly basis. So he does it daily. This way he can keep up with it. On a monthly basis, he looks at how many overrides were on the dose check feature and technologist alert report, which technologies had what alerts. And we also look at the deviation report. It is very interesting to look at that. What is the deviation report? So every time we have a alert, we assign and we investigate, we assign a label to it. Let's say it's off-center patient, or say patient was scanned with the wrong protocol. So we create many categories. And then on a monthly basis, we kind of look to see, well, this month we had a lot of off-center patients. Why is that? So then we go and we try to, emphasize that centering is important. And it is also affecting patient dose, things like that. So here's an example of I wrote this presentation a while ago. So this is the older version of the radiometric software. This is one example how we have an alert, and this patient was a pediatric patient and was scanned with the adult size protocol. So we had to go and investigate, and we had to understand why that was. Sometimes pediatric patients are pretty big, so it makes sense, but we need to make sure that it made sense. And this is an example where we had a patient that was not isocentered. So we have a lot of age-based and size-based protocols. So technologists are instructed to follow our guidelines on which protocols to use. We moved from size-based to body mass index-based protocols. So they have little tables with the BMI that they're using before sometimes they're in a hurry, it's a trauma case, things happen. We're realistic, and we know every once in a while things will go wrong, and doesn't mean you have to, punish that person. We're just trying to understand and improve our processes. So this is one example of the labels we put on all our outliers. For example, patient motions, adult size pediatric patient, and this is our monthly analysis. This particular month, we had quite a few large patients, so, we exceeded some of those reference levels that we've set. So we also can look at technologies' dose performance. I know this is a little debatable. However, they have a pretty uniform mix of patients. They get a lot of patients. So we feel like statistically it's really not that terrible of a metrics. And most of them, as you can see, can stick within these, and I won't call them thresholds. They're really just like reference levels, but we kind of try to see if they are all in the same kind of, level. So this is an example of us monitoring dose on different CT scanners, and this was an adult chest protocol, and each bar represents a different week. So during these different weeks, we have different average dose for this particular exam. So we notice, so this scanner here is back then was the only 256 slice scanner that we had, and it was brand new. We were just kind of tweaking the doses, And all of a sudden, the dose doubled. So this was an alert for us. And we wanted to understand what happened. So we found out there was a software upgrade, and somehow the max MA was allowed to go to its maximum value. So we, took actions to limit that. This is another example for investigating outliers. I'm seeing a really nice bell-shaped curve for the adult head, 20 years old older, and I'm seeing this huge increase. So on the horizontal axis, you have the CTD eyeball, and on the vertical axis, you have the number of examinations. For whatever reason, we had tons of head exams over here, around in the 45-ish, I would say, milligray. So and I also wanted to see what that is here. So after a little investigation, turns out these were studies from the new scanner we had just installed. Literally, when you click on that bar, you could see that all patients that populated were from that scanner, scanned on that scanner. And over here, we had the auditory canal protocol in one of our facilities only. All the rest were fit within the other doses. So I asked my CT lead tech, I said, what happened there? He says, well, I forgot to go there and change the protocol. So after he did that, and I followed later the dose, this is a time map of this one protocol. And now we can see that the doses have dropped to where we would like them to be. This is one example of improper positioning to where I noticed this patient over here, and I said, okay, this seems larger, this CTDI seems larger than usual. What could that be? So honestly, I randomly picked this person here. I said, why did this person have 34 milligray, and why is this person with 40% more dose? So it turns out that one was scanned in the head holder, the other one was scanned on the table, and somehow it ended up that the pitch value was also not the same. So I looked at how did I know? I knew from the scout images, they show the padding in the head holder right here. So then during our CT meeting, I did a little simulation and I explained to the technologists, if we were to scan the way we intended to and the way we recommended, the person's eye lens would have gotten a whole lot lower dose. And it really did help for them to visualize it. And also with radiometrics, we can see if the patient was centered or not using that line anyway. So another way for us to look at our doses was to compare, as I mentioned previously, with the reports that come from the dose index registry from the American College of Radiology. And of course, I put a nice graph where we fit quite nicely. They were not all like that. So this gives us a little bit of confidence that we're doing the right things here. We also participated in evaluation in a project with Dr. Bindman and Alara Imaging, where our scans were analyzed not just for doses, also for image quality. So the feedback that we got that most our chest doses are above threshold compared to other sites that they're looking at. And they also showed us what is out of range. So we had an opportunity to improve, and we put a little effort, we tried. So this here shows the result. We tried to optimize the technique using the deep learning iterative reconstruction on one of our new scanners. And we were able to kind of reduce the dose a little bit while the image quality was still acceptable to our radiologist. So I intend to do a little more of that work now that we have more than one scanner and we have this tool available, more available now. So as I said, this is a continuous project, never ending. There are new tools always coming, new scanners, new hardware, if you wish. So we have to constantly keep trying. And I think I finished way earlier than I intended to. So maybe we could have a longer Q&A discussion. Let me see.
Pavlina, I'm having trouble with my video, but thank you for that really amazing presentation. I did not mention our collaboration in the introduction, but many of those graphs that I mentioned included Pavlina's cooperation, and I think the depth of the quality improvement activities that you guys have done is really, really tremendous. So thank you for sharing that experience and expertise. There are several questions in the Q&A. It would be great to sort of hear your thoughts about. The first one, when technologists or radiologists had their own protocols, where did they come from? We've had the same at our institution, but I'm curious, how did an idea of a protocol get to your technologist or radiologist? What was the source of that they wanted to then use it themselves?
I'm not sure. I wish I could answer that. Sometimes they personally like the images better, or they probably talk to a physician and the physician say, hey, I think it's good if we have such and such reformats. I am not sure. I wish I could answer.
And I'm wondering, I'm going to talk in my next talk about surveys and our conversations with organizational leaders. I'm wondering what the general morale is among the technologists with all of these changes. Do they feel supported and that they're now have more guidance, or do they feel judged and threatened by all these changes? How is the morale and enthusiasm for all of this new sort of quality improvement work that you're doing?
I think we have a mixture of both. One thing I meant to mention and I forgot is that our upper administration has tasked us with making uniform patient care, ensuring uniform patient care in CT in all the new hospitals that are joining us. So the hospitals that have been with us for the last 5 to 10 years, they know that we are mostly advising, helping, and we always explain why we want things the way we want them. But the newer facilities, I feel like they're a little feel threatened because they don't know what to expect. And yes, we have a lot of rules. And they also, and people, let's face it, people don't like to be watched. And everybody who is being constantly monitored would feel a little nervous. So our goal is to make things better, but not to punish. And the goal is not to punish them. The goal is to make us all better.
There are quite a number of questions and answers. I think we can get through many of them if we go quickly. So someone's asking, would a more national-based minimum standard for education and training lead to better outcomes and quality versus dose and CT? You know, there's a measure before the U.S. Congress that's been sitting there for years. That's minimum education for radiology technologists. The questioner asks, it seems there's such wide variety in what is done in individual facilities. With a volume increase in technology shortages, how would this be accomplished if it were a good idea?
It is difficult. Honestly, I'm a huge supporter of having national standards because we need our professional organizations to decide what these standards should be. And if we can do better, great. But we need to have guidance on at least some minimum that we should require. Now with shortages, it's very difficult. We're trying to cross-train people, but it takes a while, and there is a lot of turnover lately, and it's very concerning because who makes the most mistakes is the people that are inexperienced, people that are in training, and which is normal. But if you're constantly training people, that is a situation in which we're inviting more outliers in our dose monitoring, if I can say it that way. Mm-hmm. We've had one technologist in the middle of the night. That was years ago. And we ended up at the airport waiting for flights, and she's like, this ER physician came and started yelling that they needed a contrast study, but she was not trained on the contrast study. And she tried several times, she could not get it, and she ended up in trouble. But at the same time, if we're short on people, these things will happen, such things will happen. So it has to be looked at on case-by-case basis.
Mm-hmm. Jumping a little bit to a more specific question, most dose monitoring software offers centering analysis, but this is subject to having both a PA and lateral scout images. Should scouts and topographs be completed in both planes? A very specific question.
Considering that the scouts do not really expose the patient to much radiation, I would recommend you use both scouts. This way your positioning is better and you are, I don't know, my personal opinion is that yes, both scouts. You're not overexposing him by that much, really.
Do you guys have a mobile CT stroke unit truck? And if so, have you found significant radiation doses recorded to technologists?
No, funny thing, we make those in Huntsville across the street, but the hospital does not have one. When we were discussing purchasing the photon counting scanner, it just popped in my head. I said, how come we make them, but we don't have them? No, I do not have experience with these things, so cannot comment.
Another question. How is the information about changes in protocols distributed to all the staff, the second and third shifts, and how do you make sure they all have the information?
Yes, good question. Our goal is to have a centralized website to where people can access. I'm just waiting to be able. I have opened a position at the hospital to hire a CT quality manager. And as soon as I get that person, that's their first task is to start working on that. But at the moment, we just, as soon as we make changes, we send them to the radiology directors, to the CT coordinator at the facility. And that's how. And they're supposed to also have a folder on their working computer that they can easily access. But sometimes IT likes to delete them, so that's not a good. we found out that's really, we need to do better than that. So
I'm jumping around a little bit, but as a question sort of back to the education piece, is the state of Alabama making strides to have registered licensed radiologic technologists? I have been a licensed registered radiologic technologist for 31 years in Texas and Louisiana.
yes, as a matter of fact, we are. There's a huge push, and efforts have been made by the Alabama Radiologic Technology Society. They have made proposals to the state for years now, and they're getting pushback, but we keep trying. I'm a huge supporter of that.
Who's the pushback from?
Not sure. Sometimes physicians, not quite sure, but I believe some orthopedics physicians, they have a little mom and pop's clinic, and they don't do enough imaging studies to hire a license, to pay a licensed technologist, I think, and also the shortage that we're experiencing lately would also affect these efforts. But I do believe it will happen. It's just a matter of time.
There are two more questions. Do you have a protocol for CCTA?
I do believe we do. Yes, we do.
And last question, you mentioned that all protocols have a reference CTDI vol and DLP above which technologists have to explain why they're exceeding it. How can the technologist change a CTDI vol? Does he or she use reference image quality with AEC that are incorporated into the exam protocol setup? Does he change the image quality or parameters manually? How does he get there?
All kinds of ways. So let's say it's a trauma or some emergency case, and they start out with an abdomen CT, and then the physician says, oh, we need to also look at the head, or they start with the head, move to an abdomen. So they pull the wrong protocol from the program protocols on the CT. Or sometimes we've had issues when they do shoulder or extremity exams, they pull a chest protocol, and then they need to open up the field of view, things like that. It can happen many ways. Or sometimes they pull, okay, we limit the maximum MA, so we let the AC do its thing, but we say, okay, it can't go past, say 600 MA or 400 MA, depends on the body mass index. But if they're in a hurry, for example, they pull the wrong body mass, the wrong protocol for the wrong body size. And so they exceed the threshold, not threshold, the reference level for that particular size of patient, but it's actually adequate for that patient. Makes sense?
Mm-hmm. Your answer makes it clear that your radiology technologists have to be pretty knowledgeable and understand both the protocols and what the benchmarks reflect and how to solve questions like that. It's not a matter of just pressing a button and getting the right scan. They have to be able to modify on the fly.
Yeah, that's the goal. The goal is not to just press buttons, but to know what is happening when you do.
Right. I believe that was, I think that was the last Q&A. Really, thanks again for that really fantastic presentation. I think doing the work of quality improvement in radiology is hard, and it clearly takes a village, as your title of your talk, to really make sure that all of the different issues and perspectives are taken into consideration and having basically multiple prongs that you're doing to try to get everything in line. So thank you for sharing that fantastic experience.
Just one comment. It takes administrators, it takes technologists, physicists, radiologists, it takes everybody for this to happen. Yes. Thank you for having me.
I want to push you on that a little bit because I think that's important. I think you guys were one of many hospitals that had radiation overdoses related to those errors, and I think the way your hospital dealt with it was really to sort of dive in to acknowledge the problem and try to fix the problem. And in some ways, I think the error is what helped your administrators come on board. And, they had a medical legal issue. I'm wondering if you have any advice for our attendees on how to get the administrators to buy in to realize this is a really important quality and safety issue that they should care about.
I think I've been lucky because our medical staff officer, Dr. Chapo, has been super supportive of our efforts. But what am I trying to say? It is good when one thing I started with him to explain to him was that, look, if you go to this hospital, you'll be scanned one way. If you go to another hospital, you'll be scanned a different way. How do you know which hospital you should go to be scanned properly? And how do you know what proper is as a patient? So I try to emphasize at first, not go straight to the dose, and the dose issue is important, no doubt, but also uniformity of care. And I think that's a good start. And if we have a good experience here, and then we can say, hey, those benchmark, our administration is very strong about showing where we are relative to other places. So also showing where you are compared to the rest of the nation, that helps very much. Say, hey, we need to do something because our protocols are, say, 25% higher than the average. I'm just making an example. We need to do something, and we don't want to be in the newspapers ever again, right?
No, it's not a good place to be. I think I want to emphasize what you just said to the attendees, which I have found in my work when we do comparative studies showing one hospital how they're doing to the next. No one likes to be doing a poor job. Everyone wants to do a best job, and showing an organization feedback how they're doing, particularly if you show them internal comparison to their hospitals A, B, C, and D, and that there's variation. I think that's very, very motivating for a lot of leaders. They want to be at the top, not at the bottom. And if it's internal comparisons where they realize in their same organization they have different facilities, I think that's really motivating. And I think that's a great place to start by generating those data to get buy-in from leadership. So, well, fantastic. Thank you so much. We get to hear from you again, I believe, later. And I think you're doing the end of the day Meet the Professor. So people should really plan to join and ask Pavlina other questions. Thank you.